Is Professor Peter Clayton, and I'm sure his talk will probably grow on you.
Very good, Colin. Thank you very much for the invitation. It was a few years since I've been to this conference. I think one of my colleagues came last time, so it's great to be here. And actually, it gave me an opportunity to review what's happening in the literature, and there is a lot happening in Costello and CFC. And so I'm going to be showing you some quite complicated medical slides, but what I will say over the top, I hopefully will be clearer and simpler. But I am also going to talk more clinically about growth, puberty, and blood sugar problems as well. I think this is the first time that I've spoken in a room decorated in the way that this is decorated. So I hope none of these creatures move around while I'm talking or possibly ask questions. Yes, so what I'm planning on doing, just a little bit at the beginning, which kind of follows on from what Emma was talking about how the pathway works. And also just to show you some of the models that can be used from a research point of view to investigate brassopathies. I'm going to talk about growth, normal growth and abnormal growth, and what can be done. I'll talk a little bit about puberty, because puberty abnormalities do occur in these conditions. And I'm going to finish off talking a bit about metabolism, which I think is a newish area that's quite intensely being investigated. So probably taking everybody back to their school days and cells. So this is a cartoon of a cell. Emma was talking about a factory or an engine, and maybe I'd call it a factory. But you've got your cell membrane, the blue bit around the edge. You've got your nucleus in the middle where the DNA is. You've got these green structures here, ribosomes, Golgi, and what is happening in this cell is that signals are coming to the membrane to tell or to ask the cell to do various things. In my case, things to do with growth and producing proteins which are processed and then extruded back into the blood and go around to the bones to make them grow. And so for a growth factor, so something like growth hormone, coming in the circulation, it locks into its receptor on the cell surface, and then it activates signaling molecules, and that's what all of those molecules, the HRAS, the BRAF, etc., are. They're all signaling molecules, and they can end up doing one of two things. They can activate enzymes or proteins which are in the cell to make the cell do things, or it can affect genes in the nucleus to generate new proteins, which then can go into the circulation to generate outputs, be they metabolic or growth. And you've seen this, you've probably seen this lots of times today, you've probably seen it many times before, but it is this pathway from the receptor that we recognise in my field, endocrinology and growth, is a pathway that's very important for the growth process. I said I'd just show you, very medical slide this one, but I think it's important just to recognise how much investigation can be done even in the rarest of conditions. So you can measure things up in the top left-hand corner. So in our case, you know, if we're worried about growth, we measure growth hormone or we measure insulin like growth factor 1. Is that different from normal? You can measure things in the signaling pathway. Or you can take cell models and you can put the mutation of CFC or Costello into that cell and see what happens to that cell. In the middle here you can take model organisms, and by that I mean things like fruit flies, Drosophila, zebrafish, tiny little fish, C. elegans, worms here, and you can generate a model of your disease, be that Costello or CFC. I mean, we, in my own group, have used zebrafish, these tiny little fish, to knock out a particular component of a signalling pathway involved in growth, and then you look at how these zebrafish grow. So it's quite a powerful way of trying to understand the complexities of diseases like Costello and CFC. You can even take cells from patients, modify them, and use them to actually look at what happens in Costello, and they can also be very useful for things like drug screening to see if a new drug might have a good impact on those cells. And lastly, you can use the classic model where you would take a mouse and you would knock out the gene and see what happens to the mouse. And you could also do drug trials in the mice. And if you get good things or positive things coming out of any of these models, what you want to do is take them into clinical trials. As Emma said, for rare diseases, clinical trials are quite tricky, but I think we've got used to now doing small numbers in clinical trials. As long as the protocols are well covered and well adhered to, you can get great results. And along those lines, and Emma mentioned this at the end of her talk, these are your pathways that you're learning an awful lot about, and these are actually drugs which are either in development or can affect each of the components of these pathways. And there is actually a clinical trial of a statin drug in Noonan syndrome for growth and bone abnormalities. And I suspect Petra might mention some of these, and Stefan might mention some of these as well, in terms of, so there's a lot of potential. There's nothing there, as Emma said, there's nothing there that we can say, yes, this is available now, but there is a lot of people who are thinking about how these can be developed.
Excuse me a minute, Peter. Tanya's mum, her eyes are all watering. She's just rubbing them. Okay, sorry about that.
Okay, I'll now move on to growth. So this is just a regular growth chart with, from infants and birth through the first 2 years of life, babies grow really rapidly but start to slow down. And that's always considered to be primarily driven by what they're eating. And then you move into a more steady phase of growth through childhood, which is more growth hormone dependent. And then at adolescence, you move into the last phase, which is the pubertal growth spurt, and the generation of sex steroids, your estrogen, your testosterone, close your growth plates and you stop growing. So there's those sort of three phases of growth. One of the things that we simply do when we're wanting to know about a child's growth is we also measure a bone age, which is just a wrist X-ray. And we look at how mature the bones are and how mature the growth plates are, and we can convert that into what's called a bone age. And here, this is a child who's relative in the lower end of the normal range for height, but actually when you plot their height in terms of their bone age, it looks a lot more optimistic. So it's good to have a delayed bone age, and that's something that if you've gone through a growth clinic, I'm sure you're familiar with. And just in terms of plotting growth data, these are on normal UK charts. You're plotting their height, you're plotting their weight. You've actually got puberty standards down the bottom here to tell whether you're early or late in puberty. This is the bone age on this particular child, which again is very delayed, suggesting good growth potential. And you need to put this all in the context of parents, so that's why when you go to a growth clinic you get asked how tall are you, how tall is dad, etc. And there's a way of putting that onto the chart. You have to sort of, if it's a boy, you have to adjust the mother's height. If it's a girl, you have to adjust the father's height. But then you'll get where the mid-parental height is, and you can then say, actually, this child is pretty short, considering they're projected to have a mid-parental height on the 50th centile, on the average. And what do we call short stature? Well, it's a bit of the eye of the beholder. You know, people sometimes have in the past used the 5th centile, the 2nd centile. So these centiles are a statistical concept, and they're how far you are from the average. So the 2nd centile means that in a normal population, 98% of children are taller and 2% are shorter. So if you're less than the 2nd centile, you're pretty short. And sometimes we also use the 0.4th centile, which is the bottom of the pink zone. So that means that only less than 0.5% of normal children are shorter than the 0.4th centile. You also need, like I showed on the previous one, to consider height in the context of parental target. So actually, if you've got a child who's in the lower centiles and their parents are short, and as long as their parents haven't got a disorder, then actually they're normal for their parents. And that helps us in our decision making about, you know, how intensively we'd investigate the growth disorder. Now, in Costello syndrome, there have been growth charts developed. They're not brilliant slides, these, I'm afraid. The Costello lines, the 50th centile for height, this is for males and females, is this blue line in the middle. And the dashed line is kind of the 5th centile of the normal range. So you can see that on average, in childhood, a Costello child will be significantly less than the normal range. And that applies to the weight here, although slightly less, because the blue line is the average and this dashed line is the bottom of the normal range. So it sort of sits a little bit. So the height is further from the normal range than the weight is. Okay, now over on the left-hand side, I have ranked things that I recognise as causing poor growth. So there's a list there, and actually in the grey, I've put on there where I think causes of poor growth in Costello and CFC fit onto that list. So we've heard about the nutritional problems in early life, and from a gastrointestinal point of view, these poor oromotor coordination, difficulties with swallowing and sucking, so not getting that nutrition in as well as could be. Endocrine, and I'll come to this in a moment, so that we do recognise that some children with these conditions have genuine growth hormone deficiency, which can be corrected. There may be problems with the bones. One example of that is if you've got a problem with your back, which happens in these conditions. Metabolic, I mentioned I'm going to come back to metabolic, and there's some interesting observations, more recent observations, that in Costello syndrome, the resting energy expenditure is increased, so you're kind of burning off more of your calories. And of course, if you've got a dicky heart, that can have an effect on your growth as well. Just in terms of weight trajectories, this is fairly newer data. So this is the weight trajectory on a normal chart, so that's the 3rd centile. So a group of Costello, quite a large group of Costello children with their normal size at birth and then tailing off. And interestingly, in this particular paper, they had looked at giving excess calories against normal calorie diets via nasogastric or gastrostomy tubes, and actually giving extra calories made no difference to the weight gain, which was an interesting observation. And then by the time these children, this Costello in their teens, you can see that the weight is dropped off quite a significant way. You do have to think about the weight in terms of the height, because if you're short, you're going to have a lower weight. And one way you can adjust for that is doing what's called a body mass index, which is where you look at your weight in relation to your height. Here's some individual growth trajectories from the Costello kids that Kath and Colin collected a few years ago. So that's somebody who from a height on the left and a weight point of view is a long way below the centiles. And here's some other examples. This one in the middle, so there's three. So one ending with a height just below the normal range, one with a final height a long way below the normal range. This one actually had growth hormone, and you can see how impactful that was, both in terms of height and over here in terms of weight. And these are more examples from the literature of growth hormone use. So here, somebody very short actually managed to get a height back into the normal range with growth hormone, along with good weight trajectory. And this is another example. This one is on the Costello growth chart. So actually, this child was average for Costello and ended up at the upper end of the Costello range. And then this is against the normal growth standards. So starting on that 50th centile for Costello, so well below the normal, and actually getting back into the normal range. So there are instances of significant success with growth hormone. So what are the pros? Well, Noonan syndrome, we've used growth hormone extensively in Noonan syndrome, and around the world in various countries there is now licenses for using growth hormone in Noonan syndrome. It increases growth, it's safe. There were always worries about the effect on the heart, but that they've been proven, it's been proven to be safe. And one of the things that I think is very important to recognise is there are benefits that extend well beyond growth in height. So growth hormone is really good for improving muscle strength and reducing fat. As a result of improving muscle strength, it improves bones. And I think many parents would say, when their child goes on to growth hormone, it improves their vitality, energy, however you'd like to put that. So, obviously, the arguments against growth hormone treatment in rasopathies is it's still relatively anecdotal. I've shown you individuals, not groups. But growth hormone deficiency is described, and I think if you're growth hormone deficient, it's appropriate to repair that by putting it back. And as I've shown you, there's clear benefit in individuals, but you have got to have major discussions with your doctor about the risk benefit, because if we're talking about Costello, we've got to think about tumour occurrence and recurrence. Now, the broader literature of growth hormone in children who've had tumours indicates that it is a safe drug. But that data can't be completely applied just to Costello or CFC. You can only extrapolate from that because there aren't enough patients. But and I think the cardiac problems also have to be discussed. And of course, it is a bit of a burden to child and family. It's a daily injection, although now we do have long-acting growth hormones which are given once a week. So I think the strategy for managing growth, you need paediatric endocrine input, you need good growth measurements, you need to have your child's growth hormone levels and IGF levels assessed. If you're considering a trial of growth hormone with your doctor, it's sensible to set parameters for what you expect the result to be, both growth-wise and for the other factors, and worth doing surveillance. And also monitoring IGF-1 to make sure that you can be cautious with the growth hormone dose.
I wanted to add to the concerns of bone growth. That there have been concerns, but there has also been no evidence in the general population. And the concern with Costello especially is the carrying on formations that occur afterward.
Right, thank you. And just while we're thinking about growth and new treatments, achondroplasia is a skeletal abnormality that you may be familiar with. Those are individuals who are very, very short. Shortness is their main feature. Their problem is because there's an overactivation of this same pathway, of the RAS-MAP kinase pathway, which results in those very major skeletal abnormalities. And these children are being treated with an agent that activates this pathway, which turns off the MAP kinase pathway. And that's been shown to have useful effects on growth. So, you know, I think in the future, people will be thinking about how that pathway can be modulated to improve growth. Okay, how am I doing? 47. Yeah. Let's move on to puberty. So puberty, like growth, it comes on a spectrum. So you have kids who have relatively early puberty, average puberty, later puberty, and for girls the start of puberty, and the start of puberty is not periods, the start of puberty is breast development, is at the average age of 11, and then in boys it's at the testicular increase, that's the start of puberty, happens at the age of 12 on average. And the axis for a girl, you've got your two puberty hormones here, follicle stimulating hormone, luteinizing hormone. They impact on the ovary. The ovary produces estrogen, progesterone. That feeds back to the hypothalamus and the pituitary to allow the pubertal process to go forward. And in boys, you've got two cell types in the testis, the Sertoli cells, which produce the sperm, and the Leydig cells, which produce the testosterone, and it's that loop that is driving puberty. So in terms of disorders of puberty, you can either have it too early or too late. There have been instances of too early described in the rasopathies, but fairly rare. I think what is more common is a delay in puberty. And the delay is no signs of puberty at greater than older than 13 in girls and older than 14 in boys. And that needs thinking about. If you leave somebody without a puberty, that has impacts on their bone development and bone strength for later life. So I think it is worth having conversations about what is the right time for a child to go into puberty. So if you want to, in delayed puberty, treatments are fairly straightforward. Short-term courses are either estrogen or testosterone just to push things along a bit. Sometimes they're needed longer term if there's been a problem with the testes or with the ovaries. And precocious puberty, there are injections that will block that axis, will block the action of the luteinizing hormone and the follicle stimulating hormone. So those are things fairly straightforward to do. So I just finished with some words on metabolism. So what metabolism is, it's the sum of the chemical reactions that take place within each cell, so what I was talking about at the beginning, that provide energy for vital processes and for synthesizing new organic material. And this has got lots of stuff on it, but what I wanted to show you is the bit at the top. So what we eat, protein, carbohydrates, fats, it's not very good for vegetarians and vegans, I'm afraid, but you get the message. And upset her. What am I going to do? So, proteins, carbohydrates and fats go into cells, they go through these chemical reactions. We chuck some of the stuff out that we don't want, the unwanted products like the urea that goes out through the kidneys. But principally what we're doing when we're taking in these nutrients is generating energy. And part of generating energy is making sure that things like glucose are available at the right sort of levels. And one of the problems that has been recognised in neuropathies is that blood sugars can be low. And I've got this, there's lots of symptoms to having low blood sugar, but in particular, children will feel hungry, dizzy, a bit shaky, all sorts of things. Sometimes it's quite difficult to know what are the symptoms of low blood sugar in your own child. And in babies, those symptoms can be very non-specific. In Costello, this condition where you get a mismatch in a baby between the amount of insulin that's generated and the blood sugar. So when your blood sugar is low, naturally you would have a low insulin level. You turn off your insulin if you've got a low blood sugar. In this condition, the pancreas, which is where insulin comes from, has an abnormality that allows it to keep on generating insulin even when the blood sugar goes down. So that's called this slightly tongue-tying hyperinsulinemic hypoglycemia. And that's been described in the literature in these conditions and is something that requires evaluation. So it's one of these things to be aware of, raise it with your doctor if it's a possibility. It's really easy to measure blood sugars. They can be done by yourselves with finger pricks. One of the things that is very important for us medically to do is to get a blood sample at the time of a low blood sugar so that we can look at all the hormones, the hormone mix. Is there too much insulin there? And it may be fairly easy to treat with frequent feeds, high sugar content, adding sugar into or sugars into the feeds, but occasionally it will need to have medication. So it is an important condition that we recognise. The other thing that can happen is this slightly funny condition called dumping syndrome. It's more sort of what we call post-feeding low blood sugar. And of course, because some children with Costello and CFC end up having management for their reflux with gastrostomy and fundoplication, that can be a risk for developing this dumping. And what happens is that when your child eats, they get a surge of glucose because it's whizzing through the system, and that triggers an increase in insulin, and then the blood sugar drops down. And there are fairly straightforward ways of sorting that out, but it's often something that's not readily recognised. So I'll just finish with, I said there were going to be some complexities, and these are from more recent literature. Here's your pathway, your RAS-MAP kinase pathway over here, and as Emma alluded to right at the beginning, these pathways talk to other pathways. So over here are other pathways that are involved with metabolism, energy generation, and what's happening within CFC and Costello is a modulation of these pathways, which is having an effect on, for instance, basal energy expenditure. And there's that paper over in the Journal of Clinical Investigation, which I have to say is an absolutely top medical journal. And then one over here talking about the dysregulation of energy metabolism in fibroblasts from patients. So I told you, you can take cells from patients and look at how they're behaving. And I think that this is important to be thinking about. I think it's a relatively new thinking in the field. And of course, if you muck up your metabolism, you muck up your energy expenditure, that will indirectly have an impact on height and weight. I mentioned the increase in the resting energy expenditure, the glucose abnormalities, And actually, one of the things that we've noted in Helena is cholesterol, and cholesterol is part of that metabolic pathway, and it's recognised that a number of children will have raised cholesterol. So if somebody's checked the cholesterol and it's raised, it's probably because of this. Still need to think carefully about the diet and things, but there's an explanation there. So, Dr. Grip, as Emma has already said, this is a fantastic paper, I think, and quite a general paper with all the recommendations for the different specialties as to what one should do. I won't go through in detail, but it's basically, checking for hypoglycemia, checking for growth, checking for vitamin D deficiency, straightforward things, and intervening if necessary. And I thought that these were quite useful little schemas to say what the core disciplines for child with Costello CFC. So you've got gastro, enterology, endocrinology, neurology, cardiology and pulmonology, so that's American, and ophthalmology, and then ancillary oncology, orthopedics, dermatology, and you're getting a dose of most of those over the course of today. So I'll finish there with a big thank you for inviting me, and of course I think to say that Colin and Kath have been stalwart supporters of these conditions and have seen this through from the early days pre-genetics to what's happening now, where there are groups around the world who are doing these really complicated investigations to try and improve the life, the health of children with these conditions. Thank you.
Thank you.